This is what we follow in SGPGI. This is a protocol. This is the half of it. I'll go on to the next section, which goes into the areas of how you screen, how you move into the triage, what are the warning signs, what do you do when the reports are positive, what do you do when the suspect is there, and then you admit the patient into your system. And once you do admit this patient into the system, you try and categorize them based on the mild, moderate, and severe cases. And then there is a spectrum of things that you need to do, which are majority related with the standard of care aspects. And then there are therapeutic aspects to this management. In today's CGR, we will discuss only 4 of these because time is of constraint. So we will discuss about steroids in COVID. We will discuss about remdesivir in COVID. We will discuss about convalescent plasma therapy in COVID. And the last one we will discuss about is the tocilizumab in COVID. Now, the Ministry of Health and Family Welfare has, after the version 4, which was published in 27/6/2020, has not updated any of these investigational therapies. So they still remain as a part of the investigational therapies. They have not altered it, maybe still waiting for more data to come, and maybe then it gets more formalized. So we will discuss, as I said, on these issues. I will start the ball rolling with remdesivir because that is the most talked topic in COVID in terms of therapies. So remdesivir in COVID. Now, this is how the bandwagon has started with the orphan drug usage status somewhere in March. And we are now in October, it received the US FDA approval. And now we are in November. And it has gone through the entire cycle of use, authorization, approval by many countries, and it has reached here. But the entire story started somewhere in the phase 1 trials initiated in Ebola virus in 2015 in October, when it was not found to be useful as compared to the monoclonal antibodies against the Ebola virus. So the Gilead, which was the major company which was manufacturing, or the innovator company, just shut it down for that time period. No, it's not working against Ebola. And then came 2020 when the pandemic started from China, Hubei. And then, since time was of essence and no new therapies were available as such, and it was a broad spectrum antiviral agent, so they repurposed it for this use, because creating a new drug has its own time frame, will take a lot of time, and therefore this was felt by Gilead as the best option, that why not try it based on the preclinical studies and the animal studies as an antiviral agent for COVID. So as you, in the bottom of the image, you will find the number of studies which are in support of this, even for the US FDA, the Act 1, the simple severe study and the simple moderate, and the further studies which are still going on, the Act 2, the Act 3, and the Caravan study in pediatrics. Now, these are studies which will keep on coming, and things will change as more information comes down the line. So what is remdesivir? So remdesivir is a potential repurposed drug candidate for COVID-19. It is a broad spectrum antiviral agent. It is a prodrug which, when goes inside the body, changes into the active molecule, which is the GS441524. It acts on the RDRP. It acts on it and prevents the elongation of the viral RNA. Now, by preventing the elongation of this viral RNA, it will help in preventing the replication of the virus. Since the virus replicates best or most rapidly in the early phases, the initiation of this drug at the early phase, it's plausible, looks the best way out. Some of the salient features of this, that it is widely distributed in the body. Intravenous route is the one which is preferred, but nebulizational remdesivir is also, trials are going on. half-life variable between 0.8 to 1.04. It is eliminated mainly by the kidneys, 63%, and by the biliary excretion, 27.8. It has got very poor penetration in the blood-brain barrier, and it is metabolized primarily by the CYP2C8 and the CYP2D6 and the CYPA3, 4 enzymes. So liver plays an important role. Therefore, biliary excretion and other things are important. But when you look into literature of COVID-19, there has been ample evidence that the evidence-based medicine has failed. I would rather say that the evidence-based medicine had failed in COVID-19. Because if you look at hard data, it's not there. So I've taken a club of the RCTs because that is what we believe, that RCTs are the gold standard. And the double-blinded placebo-controlled trials are the gold standard for RCTs. So let us see these RCTs in the context of remdesivir. If you go into literature, these are the only RCTs that will be discussed about, but I will break it up for you into two major ones. The first and the two, that is the Act 1, which was the recently published in October in the final results in the NEGM publication. And the next to this, if you see, is the Wang et al. 2020 is the Chinese study. These are the relatively better double-blinded placebo-controlled studies. The other two you see is the Goldman, the simple moderate and the simple severe. They are both Gilead-sponsored studies. They are not placebo-controlled studies. They are open-label studies, so no placebo. So if you see the standard of these RCTs, I would rather weigh my opinions based on the Bigel et al., that is the Act 1, and the Wang et al. 2020, rather than on the simple moderate and the simple severe ones. Now, let's focus on the one which has been quoted the most, the Act 1. It has been under the guidance of the NIH, and Dr. Fossey is the one heading the unit of NIH and the NIAID, and therefore Fossey is rather regulating this study. It is a double-blended placebo with low risk of bias, included 1,063 patients, 60 sites, majority in the US. It compared remdesivir in 541 compared against the placebo 522, included 88% severe cases with mean age between 59 years, about 59 years, predominantly white males, and the onset of starting, the median symptom duration was 9 days, and 26% of the patients at the inception of the study or the start of the study were on mechanical ventilated patients. And the assessment was based on an ordinal scale. Now, if you see all those 4 studies, they based the assessment based on this clinical ordinal scale, which is a 6-point, 7-point, or an 8-point. Some aspect of this has been taken into this. And then the next one you study that you see is a double-blended placebo again from China. 237 patients included, remdesivir versus placebo. All of them were severe cases, but it was, I will talk about it. It included the same, again, 11-day, and less than 1% patients were on mechanical ventilation. But the time of onset, if you see, is very different for these studies. When are they assessing the outcomes? Are they assessing it 14 days or a shorter period? Won't a longer period be better? And how are they assessing it? They are assessing it based on, one, the mortality. Yes, we all want to understand about mortality. They are basing it on an ordinal scale, which is subjective, which I will talk about. So this is the ordinal scale most of them have used. They pointed based on this, the milder cases and the severe cases. So most studies have used this at a point of 5, and then they see a change of 1 or 2 points, whether there is improvement or downslide with therapy. So unless you compare it with placebo, it's not gold standard. Therefore, the first two. So I'm talking now of only the Act 1, which is the most quoted ones. If you look into very skewedly into this, there is only one picture on the left side top, which gives you an overall time to recovery shortening. And then you can see the light of the day between the two curves, the remdesivir versus the placebo, analyzed best at the 14th day, they say that you shorten the recovery time by 4 days, and this was the only, I'm specifically saying this was the only statistically significant factor which came out from this study. Rest, you will see the graphs are merging. They are already merging. So patients who receive oxygen, low oxygen may be better than the higher flow oxygens. Patients not receiving oxygen, no benefit. Patients who are receiving higher flow or the NIV mechanical ventilation, no effect. And then patients who are receiving mechanical ventilation or ECMO, again, there is no effect. So what is the inference from these RCTs?
Another 2 minutes, please. Yeah.
Okay, so what is the inference from these RCTs is that there probably improves recovery, it reduces the serious adverse events, may reduce mortality, may reduce time to clinical improvement, and there is no difference in the hospital length of stay. And this recovery may not vary based on the age, sex, symptom, duration of the severity. Patients not receiving mechanical ventilation or ECMO, a 5-day course will provide you a similar benefit as a 10-day course with fewer harms and lower cost. So this is based on these studies came the US FDA guidelines for dosing for below 40 kg and above 40 kg for pediatrics and adults, for saying that patients who are mechanical ventilated can go for a 10-day course, or patients who are not on mechanical ventilation, you go and go for a 5-day course. If no improvement, you can extend the course. So what are these RCTs? I'll just put it a few words. So the first one, the Act 1, which is the most quoted, the endpoints have been changed midway. They call something called as a p hacking, where you fish for a number of p values, and wherever you get the significant one, you publish them. So they did something called as a p hacking, and there is no viral data. There is no viral data is available. So how can I say what is better, whether the titers were reducing with remdesivir? And only the recovery time has been reduced. Rest all is not significant. Others also have caveats. The Wang et al. Was stopped prematurely because Chinese did such a fantastic job at curtailing down the COVID that they could not recruit the patients. So it was an underpowered study, stopped prematurely. So these are the only two rational RCTs that we need to compare. And then came the nail on the coffin, was for the Solidarity trial, which was WHO sponsored, 405, 30 countries, included 11,266. Remdesivir, HCQ, lopinavir, IFN, interferon were compared on an online randomization. Severe cases included were 67. They also analyzed the adverse consequences of this drug. Remdesivir was again given for 10 days, but the conclusion was there's little or no conclusive effect on a clinical outcome or mortality. So what and whom to believe? Do I believe the WHO? Do I believe Fauci? Do I believe Gilead? Do I believe Trump? I'm absolutely confused. What should I do? And then this was a publication in the Science. In the Science, they said it is a very bad. The gentleman on the left side sitting to Trump is, or standing on the left side of Trump, is the Gilead CAO. And while the Solidarity results were still coming, they were selling this drug to the entire European market, almost a $1 billion sellout for this. So there are a lot of questions being asked. And so how can I answer them? How can anybody answer them? So let's wait for the results of better trials or more trials that will come off. So we can wait and watch for the perfect study to come, or let the Ministry of Health and Family Welfare give clearer directions, or let's continue to do what we do as of now. So what SGPGI does? So we believe that it is not a magic bullet. We really don't know if remdesivir works or not until we analyze our own data, which we have yet to do. Most countries are using it, and even the most skeptics are still using it. It is the first US FDA approved drug for COVID. It is plausible that an early use will be better than the late, as from experiences from H1N1 or for the herpes, where we want to start it within 48 to 72 hours. How late is not too late is not yet clear. Some series have suggested even 9 days, second week. So we are not sure how late is still not too late. Mild, yes, what we do is mild with comorbidities or immunosuppressed, we tend to use it. and we definitely tend to use it for moderate and severe cases, both for ventilated and non-ventilated. We prefer a 5-day course for non-ventilated and a 10-day course for critically ill ventilated and patients not improving. But yes, the 10-day course is used very less in our case scenarios in SGPGI. We do we do assess the risk benefit in patients with impaired renal functions, and we try and avoid it for patients who have an AST-ALT elevations 5 times above the upper limit of the normal.